Hi everyone, welcome to the latest edition of Infection Control Matters at the ACIPC conference, and Phil's with me.
G'day Brett, good to see you again.
You too. Well, we've managed to grab three people to have a chat to. First off, Sarah Browning, who works at Hunter New England Health District in New South Wales. G'day Sarah.
Hi Brett, thanks for having us.
And Sam. Hello Sam.
Hi Brett, nice to be here.
And Lachlan.
Hi Brett, great to be here.
So Sam and Lochlan are JMOs within the district as well. And so Sarah, you presented today, I really loved your presentation, on the piece of work you're doing with JMOs and IPCs. And I liked how you framed the start of the conversation about engaging JMOs. Do you want to tell us a little bit about that?
Yeah, sure. So in Hunter New England, we've been running it's really a quality improvement and mentorship program, which we call the JMO IPC Champions. And it's, I guess the aim of it is to engage junior medical officers in infection control, because it seems to me quite obvious that we're not doing that at the moment, certainly not doing it well, and yet there's so much we expect them to know and do. And when I look at the education resources that they have and the connections that they have with infection control, there's really not a lot there for them, even from the time that they're medical students. So we're trying to address that by linking them in with members of our staff and get them involved in quality improvement projects and research.
And one of the things you mentioned was you did a review of the curriculum do you want to tell us about that?
Yeah. Look, it is just one curriculum.
Yeah.
I haven't gone looking more broadly, but I suspect it's probably bad everywhere. So, that came up because I was actually asked to make a multiple choice question for the basic physician trainee trial exam. And having realised that my registrars know nothing about infection control, I thought I'll go and review the curriculum and then I can design an infection control question based around what is actually in their curriculum. Because I think it would be really good to start seeing questions, if they knew that the questions were in the exams, they would study the content. So anyway, what I found is what you saw in my presentation. So they refer to universal precautions in the physician's curriculum, and there is some mention of hand hygiene, but it's essentially outdated and absent.
I think it was hand washing as well, wasn't it? It wasn't even hand hygiene.
Hand washing and universal precautions. So you can sort of see why, it's just not a part of what is expected in terms of their professional development and learning that they would engage in any infection control principles. And it's assumed knowledge, right? Because we cover it in year one of medical school. They're welcomed into the hospital and off we go, but they don't get that ongoing education like nursing staff probably do. Yeah.
Now, Sam and Lochlan, how many years out of uni are you?
So we're both 2 years out.
2 years
at the
out.
moment.
Okay.
Yeah.
Do you recall doing any infection control training?
That's my question, yes.
Yes.
Oh, well, sorry.
Very little, yeah. So we did have a couple of lectures, I guess, back in first year and a couple of practical sessions on, hand hygiene and things like that. But I have experienced very little since then, in particular kind of starting in the hospital system as well. I don't think there was much at all there.
And no assessments on any of that knowledge? Or
No, nothing like that, no.
And Lochlan, same experience for you?
Yeah, it's very much a similar experience, and it's not something we would often think about in the workplace as well. I think especially as junior doctors first starting after graduating, there's a lot more clinical knowledge that's required, and there are a lot of other clinical priorities that I think take precedent over concern about infection prevention, which I'm certainly not saying is a good thing, but I think that's kind of where it is in the JMO's mind.
Yeah, cool.
And so, Sarah, I'm just curious, what's your relationship with the infection prevention team at where you're working? Why did you take this on, and did they get involved?
Yeah, so I'm an infectious disease physician, and through that I currently have the role of clinical director for the infection prevention service. My team all know what they're doing. They're excellent infection control nurses, and so I see my main role in that job is to try and engage clinicians more broadly in infection control. It seems like a big gap from where I'm standing. So, and I'm tasked with how do we address the medical officer hand hygiene issue for Hunter New England.
That old chestnut.
Exactly. And no one's been able to do it yet. And you can see no one's been able to do it historically either. So I guess that sent me down a path of trying to think outside of the box. And I think reflecting on my own medical education, I had no idea about infection control concepts until I was really doing the director job. There's a little bit in my infectious diseases training. It's encouraged, but not really a strong part of it. And so if you think about medical officers in general, and then you have your infectious diseases trainees and maybe your microbiology trainees who get a little bit of an induction. There is an expectation that you have some sort of, some sort of knowledge around infection control. And then they go on and become our clinical leaders in infection control. Yeah. And think about the research gap as well. It's so obvious to me that we don't have that medical backing pushing and promoting for better research in infection control. I think we suffer because of that.
Yeah. So what did you do? You got a bit of a program going. And
so I invented a program.
Yeah, you invented a program. We get to rename it one day when it's all famous.
Yeah. So IPC, JMO IPC Champions was the best I could come up with.
Yeah, we're going to work on that one.
So the program, what I wanted is to be able to bring together just a small group of junior medical officers each year, give them a label because it's something that they can put on their CV. So, I was a JMO only a few years ago, and you are desperately trying to build up your CV and differentiate yourself from your colleagues, and that's a huge priority for them. And, I don't want to add extra pressure to their already enormous workloads, but I think we could be working with them and leveraging that because they really do want to gain experience in these sorts of roles, be involved in quality improvement, learn more, and we can provide that if we have some sort of platform to do that. Yeah. So you need a name, call it what you want, but really it's about finding a few people who are keen to get involved. Yeah. And then I just work reasonably closely. I mean, I've been surprised how independently they've been able to actually do these quality improvement projects because supervising quite a number of projects at once.
You've put a few on the go.
A little bit, I've got a lot. I've always got a lot on the go. But really, I've been amazed by what Sam and Lochlan have been able to do in their projects, bringing together quite large multidisciplinary teams, and then I can link them in with the nursing staff, so the infection control nurses. And I think once you get to know them, you guys have been really happy to work with the infection control nurses. It's about making that introduction and showing them, this is who we are, this is what we do, and this is what we can offer you. But without that introduction, there isn't a lot of engagement between the infection control teams and the medical officers.
And Sam, so tell us about what you got involved with.
Yeah, absolutely. So I guess at the start of the year, I signed up to join this JMO IPC Champions group that Sarah was running, and we kind of had a discussion about my interests as well and what I'd like to explore, which I think was a really good thing. And I started a project in discussion with Sarah about reducing the rates of hospital-acquired infections, in particular with cubital fossa cannulas that remain in for longer than the recommended duration. And so I kind of recruited a couple of my friends, including Lochlan.
So you're involved in the same project, Lochlan?
Yeah. So I recruited them to come and help me with data collection and things like that. And we were able to get a lot of data from 4 different wards over a period of 8 weeks, which we've then used to, try to educate and have more people within the hospital become credentialed with inserting cannulas and things like that to address the issue.
And Lochlan, what did you find with this project?
Yeah, it was really interesting. I think there were quite a few key findings over that period. Mainly the barriers between removal of cannulas aren't that people aren't aware of the guidelines. I think the most clear barriers were that there was issues with documentation and ideas around how long the cannula was actually in and remained in the patient. Most clinicians were aware of the guidelines and what would be appropriate, but the issues were that we didn't have a great documentation record regarding when the cannula was inserted. The inserters weren't always documenting themselves, and that was a key issue. And although clinicians were aware of the guidelines and the need for removal of cannulation, an issue again was empowering people to be able to remove the cannulas appropriately, as well as having people around to be able to reinsert them. And so that's led to some follow-up projects that some of the other JMOs are working on as well, including increasing the credentialing for clinicians to be able to insert cannulas as well.
Yeah, awesome. I thought you were going to say something.
No, I was just going to say, pretend Sarah's not here. How did you find it? I mean, has this piqued an interest in infection prevention, or
yeah?
Answer honestly.
No, Absolutely. Before I joined, I had very little knowledge about infection prevention control, and, even just the team that I've been able to meet that, Sarah works very closely with. I wasn't aware that, it was such an extensive team, and, I've been able to meet them face to face at this conference, which I've really enjoyed as well. And I guess just even walking around the stalls here and having a chat to other people who are really interested in infection control has definitely made me more interested than I was previously, and definitely made me want to explore it a bit more in the future as well. Yeah.
And where's your career path heading, Lochlan? What are you looking at now?
Next year, I'm going to be one of the basic physician trainees up in the Hunter New England region. So I'm not sure entirely yet which pathway to go down. But
Lochlan, be bold.
What would you like to do?
At the moment, I'm thinking about going into specialist training such as gastroenterology. But I'm exploring all the options at the moment. And certainly being able to be involved in these kind of projects have been able to use my interests in particular things. One of the other projects that both Samantha and I are involved in is a project around endoscope reprocessing. And so that's something that's quite interesting to me and has been something that we've been able to be involved in because of the help of Sarah and the program.
Awesome. And Sam, where do you want to? What's your direction?
I'm not too sure yet as well, but I'm also starting physician training next year, and I'm excited to kind of explore all avenues. I'm thinking something along the lines of medical oncology. Yeah.
So one of the things there with Sarah, of course, is one of the beauties of this type of program will be you'll have in X number of years' time people who have got a better understanding of IPC in their own speciality and can be ultimately be leaders, hopefully, in that field in their own speciality.
Yeah, and look, my aim isn't to try and recruit people to become infectious diseases doctors or microbiologists. I mean, we can already sort of cover that, but we need better representation in other areas of medicine, throughout all areas of medicine. And we keep saying that infection control is everyone's business, but we're clearly not delivering on education and involvement and engagement, which means all areas are missing out because of that. So I think it will start to fill that gap over time within Hunter New England. The best thing about infection control is that it's everywhere and it's everyone's business. So it means that we can bring in the JMOs and sit down and say, well, what do you want to do? What interests you? And I guarantee I can find an infection control related, quality improvement project that we could get them involved in that is matched with their area of interest. And then they can take that to their job interviews and talk about how they've got involved while they've learnt lots about infection control. Yeah.
And your program includes the training, using the Plan Act to training framework, PDSA framework, and I think one of the things you alluded to in your talk was what the JMOs get out of it, and obviously the IPC side, but it was they're really looking for education. Is that one of the key things? Yeah, so
I was surprised by that. In some of the feedback I've collected, they were quite clear that they do want to learn more about how to do a quality improvement project, so they want to be educated about that and then gain experience in either being involved in or running their own quality improvement projects. So I think they gain a lot of skills and education in doing this. The PDSA cycles, or that framework of quality improvement, I found it really useful actually for my own my own professional development, but also being able to guide them to resources that are succinct and clear. And I felt that, particularly in Sam's case, she took to that really well and was able to lead her quality improvement project with me really just standing in the background there as support. And she did that through that framework that's available to us through the CEC.
And it's fantastic work. I've not seen anything like this at an infection prevention conference before, where we've had JMOs come along. And is this, you got plans to spread the word, Sarah, and get your colleagues at other sites and centres to do the same?
Yeah, I hope so. I'm feeling quite passionate about it. I mean, I wish that something like this had been available when I was a JMO. So, and I guess that's where my motivation came from. I've had really good feedback from the JMOs who have been involved over the last couple of years, so I'd love to see this done more widely. It's really difficult for JMOs to have opportunities to go to formal education seminars, conferences. There's no funding. And I thought, wouldn't it be wonderful if we, as the infection control, leaders and professional bodies, could get behind this group and find ways to get them to our conferences and get them presenting their work. I'm sure that we could see a shift in that culture over time if we could engage with them better at an earlier time in their careers.
And that would be a really nice way to wrap up, but I don't want to wrap up because one other question I wanted to ask. Now, you started your presentation and you alluded to it just earlier about a range of different projects, including, hand hygiene related. And in that project, if I recall, one of the JMOs was trying to lead on how to improve hand hygiene rates in junior doctors. And they identified issues around not having hand hygiene dispensers available. A great example of some baseline work that could be done.
Yeah.
And other examples, any other examples you wanted to highlight before we finish with just very briefly, other sort of projects? Yeah,
there was a few. So I worked with another JMO earlier in the year just to put together a poster about the issues we had around cannula-related Staph aureus bacteremias. There's a lot of misconceptions. For example, sometimes I'll be on a ward round and the JMO might say, "Do you believe in the cubital fossa myth?" Things like that.
Yeah.
And I'm like, what do you mean? There's just so much misunderstandings. And so I was able to send them the data and say, well, this is what we're seeing in Hunter, New England. And I can tell you that our patients are much more likely to get an infection or a Staph aureus bacteremia if they've got a cubital fossa cannula. So he developed this really nice poster, popped it up in the JMO room, in their tea room. And so they can start having those conversations about, actually, this is a serious problem for patient safety, and we know it is even locally just looking at our own data. So that was
that's a great example. Yeah, and Sam and Lochlan, to finish from your perspective, do you talking to your colleagues about this, like your other JMOs? Are they interested? Do they want to be part of the program?
Yeah, absolutely. Like, from having discussions with other JMOs, they've definitely seemed very keen to get involved. Lochlan wasn't even part of the JMO IPC group at the start of the year, and
he got
as
roped in.
part of this project, he wrote Tim in. So now he's a member. But I think it's been a really great opportunity to, I guess, have more understanding, so then we're able to share that with the JMOs as well, especially when someone raises a question or a concern. We're able to say, here are the guidelines that we've actually read, and we have a good understanding of it. So I think that's been really really wonderful.
And similar for you?
Yeah, absolutely. I think, as Sarah was saying previously as well, there's so much pressure, especially as a junior doctor, when you're trying to get onto training programs and further down in the career, to have done research projects, to have been involved in quality improvement. And so JMOs really want to be engaged and involved in these projects, and being able to be given the opportunity to do that, where it's almost a bit easier and provides an ability to create your own project, and being involved in that from that perspective has been incredibly helpful, and would be a great opportunity to be able to continue. Yeah,
awesome. I loved your talk, and great program. I heard a lot of people walking out of that talk going, really good talk, and what a great program. So well done, Sarah, and well done to you both as well for being part of it. Phil, I think that's it.
That's it.
Yep, all right. Thanks everybody for listening.